Each year, millions of adults in the U.S. are diagnosed with vascular disease. And it's no wonder, with over 60,000 miles of intricate arteries and veins throughout the human body, there are bound to be complications due to blockages, weakening of the blood vessel wall, and other issues impacting the circulatory system. With an aging population and the growing incidence of risk factors such as diabetes, high blood pressure, obesity, smoking, and the disproportionate incidence of vascular disease in our minority populations, the management of vascular health is becoming a key focus among today's healthcare leaders and providers. As with any medical disease or condition, it takes an entire team of dedicated professionals to find new ways to efficiently diagnose and treat patients, as well as to improve their long-term care. In vascular health, the leader of the team is today's vascular surgeon. Only vascular surgeons dedicate their entire training and practice to address the full spectrum of vascular health, as well as provide comprehensive care that includes preventive, medical, surgical, and minimally invasive solutions. Through ongoing education and research, as well as pioneering new techniques, vascular surgeons are on the leading edge of clinical breakthroughs that are transforming vascular health. As part of their comprehensive approach, vascular surgeons partner with other healthcare professionals to provide quality care tailored to each patient. This patient-centered model is vital to help all physicians manage vascular health in at-risk populations and promote healthier lifestyles in the future. Vascular surgeons are involved in every part of the disease process, from making the diagnosis to the management of disease. Vascular surgeons are comprehensive leaders in vascular health. Today's vascular surgeons are creating a new chapter in the vascular health story with improved patient care, better outcomes, collaboration, and leadership. Surgery is only part of our story.
Good evening, everybody, and welcome to another SVS Town Hall. I'm joined here today by Dr. William Schutz, who's a distinguished fellow in the Society for Vascular Surgery in Private Practice in Plano, Texas. Bill chairs the SVS Clinical Practice Council and has been a member of the SVS Executive Board and Strategic Board for a number of years. Bill's hospital is also serving as a pilot site for the Vascular Center Verification and Quality Improvement Program initiative that the SVS is doing with the American College of Surgeons. Before I go ahead with the introductions of our other panelists, this will be our conversation or our topic for discussion today. As you know, COVID 2.0, a pathway forward. But before we do that, I want to alert you to our next town hall, which will be May 17th, 2021. Get this on your calendar. This will be led by SVS President Dr. Ron Dahlman, who will be conducting an evening with the appointments and nominating committees. Dr. Dahlman will be hosting this with Ali Abu-Rama, who's the chair of the SVS Appointments Committee, who's going to discuss with everybody changes recently made to the Appointments Committee, the appointments process, how to get involved in the SVS, and some of the demographics and everything else from that initiative. And then Ron will host Clem Darling, who's the chair of the SVS Nominating Committee, who will have the exciting opportunity to share with us at that time the two candidates up for vice president in the election this year. At that point in time, voting will open for bylaws changes and for the vice president. And ultimately, the result of that election will be shared at the virtual annual business meeting on June 16th, 2021. So we got some exciting stuff coming up. So let's get back to the order of the day. Dr. Schutz and I are going to co-moderate a distinguished panel here. I'll present them in the order that they will be speaking. Our first panelist is Dr. Robert Molinar, who's a vascular surgeon in private practice in Michigan. And Dr. Molinar serves as the director of the Michigan Vascular Center, which will also be serving as a pilot site as an outpatient center for the Vascular Center Verification and Quality Improvement Program. So we're picking up a lot of steam in that regard as well, and we appreciate Dr. Molinar stepping up. Our next presenter will be Clayton Brinster. Clayton is a senior lecturer from Queensland University in Australia, currently working as a vascular surgeon at Oxnard Health in New Orleans. And he'll be presenting with Chip Sternberg, who's also a distinguished fellow of the SVS and professor and chief of vascular and endovascular surgery, vice chair of the Department of Surgery at Oxnard Health in New Orleans. Our next presenter will be Chelsea Dorsey, an assistant professor in the section of vascular surgery and endovascular therapy at the University of Chicago. And then our last presenter of the evening will be Linda Harris, who's also a distinguished fellow of the Society for Vascular Surgery. Dr. Harris is a professor of surgery and the program director for both the Vascular Surgery Residency and the Vascular Surgery Fellowship at the State University of New York at Buffalo. She also serves as the past president of the Association of Program Directors in Vascular Surgery. So you can see we have an esteemed panel for you today that Dr. Schutz has put together. At this point in time, I'm going to turn it over to Dr. Schutz to do the introductions and lay out the strategy behind tonight's session. Bill?
Thank you very much, Kim. I sure appreciate that. And I'd like to thank in advance all of our panelists who have volunteered to share their expertise and spend their valuable time with us tonight. And I'd like to thank all of the attendees who have dialed in virtually to join our meeting tonight. We hope that you find this informative, but also useful. So COVID 2.0, that's a different term, right? We always talk about COVID. We didn't know there were different versions of it other than mutations. What I'd like to do is talk about COVID 1.0. And after a brief kind of review of COVID 1.0, I think you can understand where COVID 2.0 fits in. So as the year 2020 ended, and I don't have to point out that this is a huge understatement, that 2020 was really an awful year, right? But as the year 2020 ended, the United States surpassed 20 million infections from COVID. There were over 346,000 deaths. At this point, as of 2 days ago on the Hopkins website, there's been now 32 million infections, 574,308 deaths. Globally, cases now account for 83.8 million and 1.8 million deaths at the end of 2020. Now we're up to 149 million cases and 3.1 million deaths. So as you can see, COVID 1.0 has continued to accelerate throughout the time period into 2021. So let's step back to early 2020. January 9th, the WHO announced there was a mysterious coronavirus-related pneumonia in Wuhan, China. January 20th, the CDC said 3 U.S. airports will begin screening for coronavirus, targeting basically the airports that had the most passengers arriving from the affected area in China. The very next day, the CDC confirmed the first U.S. coronavirus case. It was a Washington State resident who had returned from Wuhan on January 15th. January 21st, a Chinese scientist confirms that COVID-19 can be passed from human to human. January 23rd, Wuhan goes under quarantine. January 31st, the WHO issued a global health emergency. February 2nd, global air travel is restricted. February 3rd, the US declared COVID a public health emergency. March 11th, the WHO declared COVID-19 a pandemic. March 13th, Trump declared COVID-19 a national emergency. March 17th, CMS temporarily expands the use of telehealth. 2 days later, on March 19th, California issued a statewide stay-at-home order. The lockdowns then begin. March 21st, clinical trials are on hold across all of medicine, and innovation is stalling. March 27th, Trump signed the CARES Act into law. The lockdowns were extended throughout the March, April, and into early summer. There were developments of recommendations about what surgeries were appropriate to be performed and which should be delayed. Do you all remember VASCON, the protocol that Dr. Forbes developed as to how severe the pandemic was in your area and how you should triage your surgeries? There were supply chain issues. PPE became very hard to get a hold of. We saw vascular surgeons and vascular trainees repurposed into other areas. Telemedicine, again, was brought online, and as it turns out, in April, it accounted for 16% of all Medicare spending. Over this part of the year, physician and hospital revenues plummet. A lifeline is extended through the Paycheck Protection Program and advanced payments through Medicare. May 28th, the U.S. passed the 100,000 number of deaths from COVID. Around this time, in-person VAM was canceled and switched to a virtual meeting in August. There are no in-person meetings in the vascular world for the rest of the year. The SCVS had already been canceled. VEITH, Charing Cross, VESP, and all the remaining regional societies were canceled or went hybrid. June 2nd, U.S. COVID cases reached 2 million. Then there's a gradual and uneven emergence from surgery lockdown and personal lockdown. But then summer came and there was a second surge. By August 17th, COVID is now the third leading cause of death in the US. However, good news is around the corner. September 3rd, it was identified that steroids can reduce mortality in severe cases. Sanofi and GlaxoSmithKline began human vaccine trials. Then September 23rd, there was the announcement of a new, more contagious strain of COVID-19 discovered in Houston at Methodist Hospital. September 28th, global COVID deaths surpassed 1 million. And then in fall, the third surge comes. By this time of the year, Medicare spending was 16% below expected, reflecting the reduction in the number of elective procedures and care being performed. October 2nd, President and First Lady test positive for COVID-19, and our president is hospitalized. He's treated for 3 days before he leaves. October 19th, global cases, 40 million. October 22nd, the FDA approves remdesivir as the first COVID-19 drug. And then just 2 weeks later, November 4th, the US reports an unprecedented 100,000 cases in 1 day. November 9th, the FDA issues an emergency use authorization for Eli Lilly's antibody treatment. November 16th, Moderna reveals vaccine efficacy results. November 18th, Pfizer/BioNTech vaccine is shown to be 95% effective. And then December 11th, the FDA gave EUA for the Pfizer-BioNTech vaccine. And a week later, the same for Moderna's COVID-19. So as you can see, COVID disrupted everything across our personal and professional lives, all types, all practice settings. It's affected our trainees, clinic visits, and revenue streams. However, there are vaccines now. And in fact, as of this week, 25% of the country is fully vaccinated and 40% have had at least one of the vaccinations of the two required. We're seeing improvements in supply chains. And this is where I think COVID 2.0 starts. We have the vaccine, the infrastructure has been in recovery mode and seems to be much more effective now. And I think it's time to pivot as we enter COVID 2.0. So now that we've reflected on what we've been through the last year, we'd like to learn from our panelists as they share with us their experiences and their recommendations, and then plan for the future. That, I guess, Kim, it's time to introduce our first speaker, Dr. Molinar.
Go for it, Bill.
Okay. Well, it's my pleasure to introduce Dr. Molinar. He's a private practice vascular surgeon at Michigan Vascular Center, and he's been there for 22 years. He's a proud graduate of the University of Notre Dame, which I personally will not hold against him. He's completed his general surgery residency and master's of surgery degree at Michigan State and completed his vascular surgery fellowship at Vanderbilt University. He joined the Michigan Vascular Center in 1998 upon completion of his fellowship and worked with his partners to develop an endovascular program. He's been active in clinical research with Michigan Vascular Research Center as an investigator in over 70 clinical trials, 42 of which he was the principal investigator. He is engaged in teaching as a clinical professor of surgery at Michigan State University with vascular fellows, surgery residents, and medical students. He has a strong interest in OBLs and has helped develop the Michigan Vascular Center VERST OBL back in 2005 and their second one in 2013. He is currently the executive chairman for the new, actually not the new, but for the SVS section on outpatient and office vascular care. That's our OBL section. He serves on the executive committee for the SVS PSO VQI and has participated in the SVS task force on vascular verification. So let's see, there's one interesting fact that Dr. Molinar has allowed me to share with you. He enjoys working on his own vehicles and has just passed 300,000 miles on his work SUV. He enjoys working outdoors, and apparently, this is self-described, Rob is a demon on his zero-turn mower. Thank you, Dr. Molinar. Looking forward to your presentation. The floor is yours.
Well, thank you very much. I appreciate the opportunity to be here this evening and to participate in this important town hall meeting. All of us have been significantly impacted by the current pandemic, and while many of us had hoped that the changes in our clinical practices would somewhat revert to normal, we have to recognize that many aspects, many aspects of our practices have changed and will be continued to be changed. Tonight, I will be addressing our response at the Michigan Vascular Center to the COVID-19 pandemic. I also will revert back to sort of COVID-1 because I think those practices and policies that we established are actually helping us through this COVID 2.0. I'll review how we manage the challenges, some of the impacts to our practice, and some of the challenges we continue to face. I'd first like to recognize my group. This is our team, the Michigan Vascular Center. We're now in our 58th year, and we're a true group practice, which I will detail shortly. As disclosures, again, I will be mentioning that we do have an OBL, and I am the executive committee chairman for the SVS section on outpatient office vascular care, the SUVC. So our group was started in 1963 by Dr. Albert Maqsood. I just want to give you a perspective of who we are so we can compare things as we go forward. He, Dr. Rick Sharon, and Dr. Carlo DeLomo established a group practice in which it was evident that the patient comes first, the group comes second, and the individual comes third. And it's by having such a philosophy and a way of doing your business that we've maintained one of the largest private practice vascular surgery groups for over 57 years. And I'm very proud to participate in that group and look forward to another 50 years. So about us, we have 10 vascular surgeons. One is part-time. Actually, we onboarded 2 new surgeons just this past year during the COVID pandemic. So that was quite interesting and challenging in and of itself with the drop in the volume of patients. We have 4 nurse practitioners. We have 3 PAs. We have 4 office locations, each with an accredited vascular lab, and one of those offices is Vein Solutions. We have over 100 employees. We have 2 OBLs. We have a 2-year vascular fellowship. We have 3 hospital systems which we cover, and we've covered them 24/7 since 1963. And we're a true group practice that provides comprehensive team-based vascular care. So again, back to just how we sort of worked our way through that. And COVID 1.0 back in March, we were heavily impacted by the drop in patients and the cases, and all of our hospitals dropped all elective procedures. So we had to establish some way to try to focus our practice and maintain our ability to take care of patients and keep our offices open. So we did develop a plan to triage patients for urgent and emergent procedures. We established phone and telehealth protocols so that we could try to identify which were more urgent situations and to establish a communication pathway with our patients. And we implemented COVID precautions and procedures to keep our offices and our OBLs open, to limit visits to the more acute programs or problems, to protect our staff and our patients, and to develop the screening protocols and visit parameters. So immediately we formed a multidisciplinary COVID response team. This team was made up of some of our team leaders from multiple offices. There was 1 physician champion and 1 nurse practitioner. And the team continuously monitored the COVID situation. We looked at both CDC, federal, state guidelines and requirements. The members of the team were available at any time if there was an acute situation that occurred or if there was a question. For patients coming to the offices, we first had a telephone screening protocol in place to ensure patients were free of COVID symptoms and had not been exposed to anyone acutely ill. Since access to COVID testing at this time was really non-existent, We needed a system to attempt to avoid potentially COVID positive patients coming in through the office setting. So we had to have these screening situations set up. And again, upon arrival, all patients were again screened, both at the front desk check-in and as they were taken to their room for room intake. Our staff were asked to attest to their current health status and record their temperature upon arrival. Any staff that experienced any potential COVID symptoms were asked not to report to work. And then we did a lot of PPE training. I mean, just the donning and doffing of the PPE and the appropriate method of doing so had to be taught to our staff because this was new. We didn't do this on a routine basis. So that was required, and many participated in making masks because the masks weren't available. So had a lot of the staff and employees that were at home sewing masks just so we could provide coverage and do what we needed to do to stay open. One of the things that our team put together was educational pamphlets. So this is an example of one of the educational pamphlets we put together at the onset. And it really centered on patient care, on employee wellness, and on the PPE that was available and how we would utilize the PPE. So it was an educational process, and it also included PowerPoint presentations, as I'll show you here in just a minute. But it really was not only to assist in the training and management of the COVID pandemic, but also to address the wellness and the concerns of our staff, because this was a very scary time for everyone involved. So we really needed to have everybody working together as a team. The employee wellness, we really thought was one of the most important components, because if we were to become ill or our staff were to become ill, then we would no longer be able to provide the patient care that we wanted to be able to provide. So we recognized that if we lost staff, our mission of patient care would be jeopardized. We felt it was our duty to inform, educate, and provide wellness resources to our staff. So this is an example, again, of a bulletin that we put out, and we frequently had these bulletins and pamphlets that would continue to stress the education that was important. And I'm particularly proud of our leadership for establishing this, because it just was a very angst-filled time. I mean, there was a lot of fear going on. People, should we have patients coming in? Should we shut down? What should we do? But our focus at the group was to say, we want to maintain our practice. We want to be able to provide care to the patients that have a need. This is an example of a PowerPoint that was put together. Again, we'd meet with the staff. We've had educational sessions talking about, how we protect ourselves, all of the things that we heard, throughout the year about protecting yourself, cleaning, disinfecting, what the protocols would be in the office for cleaning surfaces, cleaning equipment. So we had all of these protocols and policies put together, and we really held each other accountable for that. Prevention, again, as Bill had mentioned, there weren't any, it really wasn't testing, there were no vaccines, so we had to really work on prevention. So we had to avoid the close contact with people who were sick. We had masks mandated, not just masks, but shields. So if we had close patient encounters, we had shields for the patients and shields for the providers so that they were protected during the acute phase. And again, a lot of disinfecting, a lot of cleaning, and a lot of reinforcing of the protective mechanisms. And again, for us, primarily it was to protect our staff and our patients, but we knew if one of the physicians got ill and brought it to the office, or staff got ill and brought it to the office, it could spread, and then we would have a pandemic within our office. So it was really important for us to consider how we protect ourselves and what the protocols would be to do that. There were frequent reminders, and we again had updates periodically throughout the year. So here, this is July 10th, 2020, another pamphlet put out, published for our staff, for our employees, that just went over universal precautions, what our travel restrictions were for ourselves at that time, PPE, and the other health surveillance mechanisms that were important to keep our office open and our OBLs open as well. So as we're weathering through the storm, now we're in mid-2020, and we knew that the financial situation was going to be challenging. So we applied for and eventually received the PPP loan, the Paycheck Protection Program, which Bill alluded to. And that was designed to cover 2.5 times your payroll costs. Businesses were eligible if you maintained your employees and maintained their compensation. So the loan was set up to be possibly forgiven if you met all those requirements. Now, as of yet, even though this was last year, we still are not sure whether or not we have been forgiven of this PPP loan. I mean, we'll go through the process and do the application. We feel we did everything appropriately, and hopefully it will be forgiven, but that is still some risk we hold. We also received an HHS stimulus grant, which was based on a % of your historical billing. So that helped as well. Both the PPP and the HHS stimulus helped us to be able to maintain the practice and maintain all of our employees. But overall, revenue was down about $2 million for 2020. So financially, it was a big hit. We were very fortunate that we had our OBL, because that did give us an opportunity to still do procedural work and to really provide care for patients that were greatly in need of it. If you look at our OBLs, they were initially established for hemodialysis access regions, for the end-stage renal patient. And, you know, during this pandemic, the clotted fistulas, the clotted grafts, the infected catheters, the poor clearances, the prolonged bleeding, those things didn't stop. And really, there wasn't an option to get them through the hospital system. So we really were able to provide that. And then there was also a lot of critical limb ischemia that we couldn't get through the hospital systems, and we didn't feel comfortable in delaying a person with rest pain and ulceration. So, you know, we were able to still provide those services when really the hospitals were bottlenecked. So our OBLs were critical in our situation. Again, it may not be for everyone, but it gave us the opportunity to have a safe and very effective location for outpatient procedures. And patients actually preferred that because they did not want to go to the hospital setting where they felt it was a COVID hotbed. So we had safe protocols and a safety environment set up that we mandated that all the team members participated in, and it enabled us to continue to keep our offices open. We met our payroll every 2 weeks. We maintained all employees. They didn't have to be furloughed. They didn't have to go on unemployment. And we were able to provide the financial resources to continue to obtain the needed PPE and the continued protective policies that we had established. So now the current COVID surge is upon us. In Michigan, as you probably are aware, we're kind of at the top of the list with the COVID surge. And in our hospital systems, I actually was talking with one of the intensivists last week, and the number of COVID positive patients now is higher than it was in the peak in the pandemic of 2020. One of the hospital systems is not allowing for patients to have any planned admissions or any same-day admissions. And all 3 hospital systems are not fully efficient from 2020. So even though we've maintained full ability and staff and the ability to be productive, the hospitals have really slowed down. They furloughed a lot of people, they furloughed a lot of nurses, and for one reason or another, they're not getting that staff back. So we have delays in getting, you know, stat lab results can be 4 hours. X-rays can be a day delayed, and we can't schedule outpatient procedures very easily. So, you know, our office-based procedures still give us a great opportunity, especially for those hemodialysis issues, but also for those patients with critical limb ischemia. And it actually probably is offloading the backlog at the hospitals and helping during this time. So we're fully open and operational. We do recognize that there will be additional costs to provide services, and then our overhead has and will increase. So if we look at our 2020 experience, our overall medical costs are up $25,000. Personnel costs are up $40,000. That's including training. You have some turnover. There's a lot of, you know, time spent with training and lost productivity for the compliance that has to be there based on federal, state, and local mandates. And there's increased costs such as plexiglass barriers and the patient and staff check-in stations where we have to record temperatures and COVID symptom attestations. I know if we look at our overall expenses, the costs of all the PPE have gone up. I mean, the cost of gloves have doubled. So we know that the N95 masks, the gloves, the gowns, the disinfectants, those are all going to increase to that practice cost going forward. But we're still committed to providing acute care to our patients. Certainly the hemodialysis needs and the critical limb ischemia will continue. The hospitals will, I think, eventually open back up, but their efficiencies are still quite poor. But we anticipate that, by we look at how we did things in 2020, and we really haven't stopped. We haven't taken our foot off that gas pedal. So we still have our COVID task force in place. We still change and implement changes to the policies so that we're doing the best that we can to provide safe and continued care to our patients. And if the hospitals get hit harder, our OBLs will still be there for us to still offload for the critical limb ischemia issues that we can deal with, and for those patients with hemodialysis issues that still need to have dialysis 3 times a week. So again, I'd like to thank everyone. I'll stop there and answer any questions anyone might have, but I appreciate the opportunity to participate this evening.
Thank you very much, Dr. Molinar. That was excellent, excellent. I was very impressed at your organizational abilities to get these pamphlets out to your staff. Let me ask you one question while I believe we get a polling question ready for the audience, or head to text to chat as well. But as you mentioned, not only are the PPE costs going up and the other supplies going up, one thing we've had trouble is just actually even getting our orders filled. Now that's gotten a lot better lately, but do you have any insights or suggestions, and how did you handle this when you're trying to place an order and your vendor just can't get you the product?
It was very difficult last year. I mean, we wanted N95s, but we couldn't get them. We had to go to KN95 masks. There was a shortage of narcotics for doing procedures. So, there was a shortage of heparinized saline. There were a lot of shortages on a lot of different things, but we really had an aggressive task force that was going out and trying to find these avenues and these supplies. Gloves right now we've had some trouble with. So there's apparently somebody bought out another company, and but we've had really the task force working on it all the time. They're looking at our burn rate of PPE. They keep an inventory, and as soon as they see us getting low in an area, we're going out to try to find it. So we've just had a very aggressive approach at trying to continue to get the PPE and the supplies we need.
So Bill, let's move on to the next speaker. You'll have to unmute yourself as well. And we'll do some audience polling questions later. Let's also encourage the audience, if you have any questions you want to ask the panelists, feel free to text them in. Again, this is the text to the panelists texting function.
Yeah, thanks, Dr. Hodgson, and thank you, Dr. Molinar, for your presentation on financial and practice recovery in the community setting. And we'll have time for more questions following all the presentations when we have our full panel discussion. With that, I'd like to introduce Dr. Clayton Brinster, and he will be presenting on behalf of himself and Dr. Chip Sternberg on financial and practice recovery in a academic setting. So first, a little bit about Dr. Brinster. Born and raised in Philadelphia, he completed his undergraduate degree in medical school and general surgery residency and an NIH-funded research fellowship at the University of Pennsylvania, which happened to be the same hospital where he was born. He managed to cut the cord and completed his fellowship training in Boston at Mass General. And based on this experience, he developed an intense interest in evolving endograph technology and extended his training in Europe with 2 intensive 3 to 4 month fellowships in Barcelona and Nuremberg, respectively. Not bad places to go for some extra training, right? In order to gain experience with evolving aortic endograph techniques, he returned from Europe to join the section of vascular surgery at the Ochsner Clinic in New Orleans, where he serves as the medical director of the vascular lab and associate program director of the vascular surgery fellowship. Dr. Brinster's clinic efforts focus on complex aortic disease, and his research efforts focus on aortic and carotid disease and the effects of COVID-19 pandemic on academic health systems and on emergent cardiovascular conditions. His extra clinical teaching focuses on directing a weekly oral board style review course for their fellows. Dr. Brinster lived in Europe training and traveling for a year after completing his surgical training before starting his first faculty position. Now, as for his mentor, Dr. Charles Chip Sternberg III, Professor and Chief of Endovascular Surgery and Vice Chair of the Department of Surgery at Ochsner Health. He performed his undergraduate studies at Brown and medical school at Duke. He did his general surgery training at the Medical College of Virginia and his vascular fellowship training at Emory. His entire 25-year professional career has been at Ochsner Health in New Orleans, where he has been the Division Chief of Vascular and Endovascular Surgery since 2006 and the Vice Chair of the Department of Surgery since 2013. He is the past president of the Southern Association of Vascular Surgery, and I would like to put a plug in for his presidential address when he was president. It was one of the best presidential address that I've ever seen at that meeting. He's also been a past president of the Vascular and Endovascular Surgery Society. Fun fact, even after a nasty tib-fib fracture at a prior VES meeting, skiing, Chip still enjoys skiing, so good for you to get back on that horse. Well, with that, we'll turn it over to Dr. Brinster. The floor is yours.
Great. Well, I'd like to thank the panel for their participation and for including us from Ochsner. We've done a little bit of work looking at the cumulative financial impact of the pandemic on our division. We first reported these results at the Southern in January, which was the first meeting that had live participants, although it was mostly virtual. But we've continued to look at this over time and are delighted to be included tonight. So thank you very much. The COVID-19 pandemic, as we've heard and everybody's experienced, has had a devastating financial impact that continues to evolve over time. And the Medicare CARES Act, as we've heard briefly tonight, was signed into law in late March 2020 in an attempt to avert or lessen these losses, but it was based only on an estimate of total financial loss during this interval of -7% to 15%. And that really was based on expectations for the first into the second quarter of 2020. Here's a brief graphic showing hospital losses through the third quarter and projected through the end of 2020 compared to CARES Act funding and PPP relief funds. And you can see here in the left column, the red signifying losses expected and anticipated, totaling upwards of $325 billion, and total relief dollars available from those combined forces of the CARES and PPE only totaling about $175 billion. A little bit more specifically here, we see the adjusted operating mean margin index for hospitals nationwide from the first quarter of 2018 through projected quarter 4 of 2020, and that data has just been made available. And you see that large red downward bar, of course, is when the pandemic first struck, especially noted here in an intensive epicenter in New Orleans. Negative margins reported, and the CARES Act implementation there in the purple and yellow was instituted in late March, early April in an attempt to lessen the severity and rapidity of those losses. And you can see it slowed it down temporarily, but still in quarter 3 and 4, and now we know into quarter 1 of 2021, those losses are severe and ongoing. The bottom line is that most health systems already function at slim to net negative financial margins, with the average overall, as you can see from those earlier metrics, about positive 3%. The CARES Act relief funds have helped quite a bit in most hospitals and health systems, but represent only a fraction of the losses incurred and those about to come. And along those lines here, we see state budget shortfalls that could be the largest on record. And in the right panel, though, for COVID, for 2020, those numbers are established. But as you see, in 2021 and into 2022, the losses are still quite severe when compared to 2 major financial downturns in this country in the modern era in 2001 and then later in the 2009 to 2013 years. And these are in billions of dollars here. The objective of our initial study was to examine the continuing impact and evolution of the financial changes incurred during the initial pandemic. And we've extended those studies that were initially reported at the Southern Vascular to include data up until the first quarter of 2021. OR, cath lab, vascular lab, and outpatient clinical volume were reviewed in our academic division, and returns and margins, insurance payer mix, and RVU generation were recorded, and the respective trends were analyzed. Two intervals were established for ease of comparison. The first was a conglomerate of monthly data from the COVID era, defined as March 2020 through February 2021, when our accurate data was available up until. And that was grouped into 4 cohorts of 3 months each to more clearly delineate exactly what was happening over time rather than a month-to-month comparison. The pre-COVID era, which we were comparing our COVID data to, involved monthly averages from a 14-month period from January 2019 and till February 2020. And we picked January 2019 rather arbitrarily, but to give us at least 1 year of data just to increase the power of our control group, so to speak. But looking back, the numbers in the years prior did not change dramatically from those. Data, including revenue, volume, profit margin, were based on real-time values, importantly, and not Medicare or Medicaid extrapolation estimates. And in researching most of the reports from healthcare centers, when it's involved with financial data, it's almost always based on extrapolation estimates or what a health care system is comfortable releasing. But in our circumstance, we have the benefit of having that accurate information. We first looked at payer mix because one of our first questions is, when people are losing work, when they're disenfranchised by the pandemic, are they changing insurance patterns? Are they losing their insurance? And in fact, we did see a rather abrupt and stark transition in coverage in our area, and the most startling of which is the drop in Medicare and the increase in Medicaid. In fact, we saw a 3% shift in payer mix from Medicare to Medicaid, and that, of course, represents increased vulnerability and decreased profit margin for a large health center. In terms of our division specifically, when we looked at procedural volume through the pandemic, that left-hand column representing a monthly average of those 14 months before the pandemic, of course, those 3 months during which the heat of the pandemic, the most severe restrictions existed, we saw a major downturn, but a fairly rapid recovery when those restrictions were lifted in the 4th month of the pandemic in June of 2020, which has continued and slightly increased. And the conglomerate monthly increase in procedure volume has been about 2.5% per month. When we look at more granular financial generation information in terms of RVU, the monthly averages were compared in the same manner. The pre-COVID column for a monthly average is in the left, and there was a sharp downturn, of course, during the height of the restrictions, and an overage of 13% in that first 3-month cohort after restrictions were listed, and a gradual return to about pre-COVID levels in terms of RVU generation only. A conglomerate monthly increase of 7.7% after that initial 3-month downturn during restrictions has been seen. Perhaps the most accurate estimation of the financial health of a vascular division, or any division in a health system for that matter, is the hospital margin or total professional revenue, which is listed here in hundreds of thousands per month. And we see the pre-COVID level there in the left-hand column. Of course, a very sharp downturn as expected. Overages again in that first month to 3 months after the initial downturn. But when we look at it, interestingly, and in contrast to increased procedural volume and RVU generation overall, we see an even break here in terms of the hospital margin. And that really is a testament to many things, but probably the most important is that dissolution or degradation, if you will, of our payer mix and the substantially more patients seen in with Medicaid coverage. In terms of recovery, the projected overage requirements to achieve financial equipoise based on just a simple extrapolation or ratio modeling would involve a really aggressive margin overage of about 10% per month for almost 1.5 years. And that's almost impossible to achieve without a radical change in demographics or market share or other major infrastructure factors. A slightly less aggressive, but still very challenging 5% overage per month would be required for almost 3 years sustained to make up just 3 months of lost revenue during the height of that early pandemic. A little bit of background in terms of overall economic factors, which when we're just talking about healthcare, we may be naive to or not consider very carefully, but it really puts everything in perspective and crystallizes exactly how severe this issue can be and may be when we look at the big picture. And that involves a $2 trillion basically vanishing from $21 trillion US economy in the early pandemic. And that's more akin to a flash depression rather than a recession, which is the word a lot of economists and healthcare economists have thrown around in terms of categorizing and classifying what we've been going through from a financial standpoint since March of 2020. Again, the US Department of Labor reported as late as the beginning of the fourth quarter of 2020, almost 30 million are still receiving unemployment as of the beginning of the fourth quarter. The Urban Institute along those lines issued preliminary estimates for the more than 10 million workers that are noted to have lost healthcare coverage. And these are startling factors when you consider what that actually translates to in terms of patient care and the ability of patients to afford necessary care. And that is that 30% or so of those 10 million will be completely uninsured and unable to pay for needed care. Another third will be eligible for Medicaid, but as we saw earlier and have briefly discussed, Medicaid offers coverage, but in terms of financial health of an institution, that's a heavy burden for an institution to bear. An additional 1/3 will be eligible for exchange-based coverage under Obamacare, which does provide coverage like Medicare, but it's financially unhealthy and institutes a burden for the said or respective healthcare center. Actual uptake rates for the predicted Medicaid coverage and the extent of growth of uncompensated care will depend on the severity of each state's downturn and their ability, frankly, to bounce back. What is their economy based on? Are those industries going to be successful in a post-pandemic or evolving pandemic world? In addition, normally 18 months are required from the onset of a typical recession for the effects to be realized in the hospital industry in terms of cash flow and revenue. And we're not even in that period yet, and yet we've seen dramatic downturns. The amount of structural damage, as I just mentioned, in each respective state or local economy will really determine the long-term health impact on the healthcare payer system. And that is mostly due to the fact that it's just not the healthcare or revenue generated by a hospital that can affect the finances of an institution. It's very easy to see that oil and gas and other supportive industries will have an effect as well. The hospital budget for 2021 through even 2023 will be affected by the number of total permanent business closures in the wake of COVID-19, and we're still realizing what that might be. For a 9 to 24 month interval beyond what we've experienced in 2020, a significant decline in commercially insured patients has been forecasted by several healthcare financial entities. And the result is an increase in Medicaid, like we were just discussing, increase in exchange, and even uninsured patients. In addition, Medicare will likely expand by a consistent 2.5 million people per year as the baby boomer generation ages. And all these factors lead to the erosion of the current somewhat fragile payer mix and can upset the fragile balance of the healthcare margin, which we discussed before, is razor thin even in successful medical centers, usually between 0 and 3%. And this leaves health systems vulnerable to downturns financially. In addition, collection rates from the remaining commercial payer patients who have high deductible plans is likely to deteriorate, and that's based on a number of different societal and economic factors, including interrupted employment, less reliable paychecks, less reliable healthcare coverage even when there is employment, and the typical familial cash flow problems, which really have been augmented by the pandemic. There will be a rise in so-called self-pay bad debts and health system burden as a result of that, and a significant decrease in both insured and uninsured patient self-pay collection rates. Actions health systems must or can undertake to ensure profitability in the wake of the pandemic or in the ongoing pandemic are many, but several important ones include working with secondary commercial payers to improve rates and terms of payment, communicating more effectively with patients and patient care groups in advance about cost, and ensuring they receive value for what they spend in terms of procedures, scans, tests, etc., including estimating the actual cost of care for patients more accurately and preparing for consumer pressure to reduce those costs without necessarily a coherent or algorithmic plan, just a demand. Exerting pressure on both consumer payments and payer negotiations to increase revenue is a strategy that many have suggested moving forward. In addition, it is realistic, even when you take a quick look at what's happening in India these past few weeks, in Brazil, in an ongoing fashion, that additional waves of infection or COVID variants will develop before quote unquote herd immunity is achieved here and in other nations. And if there are additional mass cancellations of elective cases, like we just heard is happening in Michigan, with resource allocation, which is limited solely toward COVID-19 related care, as was the standard in the early pandemic, this will result again in severe and irrecoverable losses. So like we heard about some very sophisticated and ingenious plans to maintain revenue in the private sector and OBLs, additional strategies like that will be certainly required in the larger scope for the healthcare environment. Large-scale, multifaceted federal government infusion of funds seems to have been the really only effective and maybe the only realistic avenue forward to financial stability. But after the initial CARES Act and PPP, we really have not seen a coherent plan in terms of stabilizing the healthcare economy when these losses inevitably catch up to what's already been instilled into the economy. At our institution, the early pandemic resulted in a 3-month sustained divisional loss, which was severe but self-limited. Clinical volume and profit margins returned to pre-pandemic values in month 4 of the pandemic. And CARES Act supplementation overall has grossly underestimated acute and long-term financial need. And the end result of that, I think, has really not even been fully realized. Pandemic-induced payer mix reorganization or dissolution will continue to erode profit margin for large healthcare centers. And for our division in particular, aggressive monthly overages and salutary return may take years to achieve financial equipoise just based on those 3-month losses, as we've seen the trend of financial data for the last 9 months after that downturn. Alternative novel strategies, as we heard a little bit about in the first presentation in the outpatient setting, and novel strategies in larger healthcare centers will be needed to reduce losses. And additional CARES Act or federal government funding really is the most realistic and only realistic potential at this point to achieve financial stability going forward. Thank you very much.
Thank you very much, Dr. Brinster. That was an excellent presentation, and it's interesting to see that you dove into an area that a lot of us didn't even think about, is with all the people that are now unemployed, and that takes them out of the commercial insurance realm and shifts your payer mix. And as you know, payer mix is the big buzzword, and when you're in the C-suite, as to how well your hospital and system's going to be doing as you try to meet budget. So that's that even makes your initial analysis of your
to continue perhaps a trend back to above or meeting the pre-pandemic values. The only real tangible reason on superficial analysis, of course, we'll continue with this, is that we have seen a major shift. And interestingly, our commercial payment percentage has been stable. Our Medicare has drifted down. Normally, in the pre-pandemic world, one might think that would yield bigger dividends if Medicare is decreasing and commercial is staying stable. But I think there's a larger untold story there of how in not only the increased percentage of Medicaid patients, but those patients typically are higher need, present with later pathology, and are more costly even before insurance is evaluated because they're presenting with tertiary quaternary problems. So I think that along the lines of that financial data, which takes sometimes years to really bear out just from a numbers perspective, when you look at vascular pathology, it's a similar trend that it's not always identifiable in the exact moment that you analyze things, but these patients have chronic severe problems, and that really may become an issue as more patients transition to uninsured and burden the public healthcare system, or Medicaid and burden the private and public system as well.
Well, and Dr. Sternberg, I mean, does this information and these numbers, does it make you a little nervous as to, the financial future of your division and competing for health dollars in the auctioneer health system? And have you anticipated any changes that you might have to make or be forced to make to to deal with future funding cuts?
Well, I think that our hospital system really did a good job in 2020 in terms of being able to flex the workforce to be able to deal with what was we were a very early hot spot for COVID. And our hospital system didn't furlough anybody. We didn't have any pay cuts from the doctors on down. And amazingly, at the end of the year, at 2020, the hospital system, which is about a $6 billion enterprise, made their budget. How in the world did we do that? Well, we did it because we got a lot of federal money to fill that gap. And I think everybody's concern going forward is that that's sort of one-time money that's not going to be recurring. And there's clearly been a degradation in the payer mix, and it only takes a few percent change from Medicare to Medicaid, and that translates into a lot of revenue for the hospital. So I think we're all holding our breath to see what happens with that in terms of the payer mix issue going forward.
Bill, maybe Dr. Brinster can unshare his screen and we can go to gallery view. It might be worth kind of going around to the panel and asking what impact this has had on various incomes from the different panelists, particularly those in health systems that have, how shall we say, reduced contractual requirements.
Linda, do you want to go first?
In our system, they were able to, again, get some of the federal funds, but it definitely did decrease take-home income for all of the faculty. We were able to maintain all of our staff, although for a short period, people were, their time was decreased and they were working from home. But going forward, again, we don't know what's going to happen because COVID is up and down. Again, it's up a little bit in our region again. So the finances going forward are still concerning. Our division is stable at the moment. The hospital system lost a boatload of money and are at potential risk. And, that's the whole city. So all the hospitals can't fail or we're going to have a disaster. But in the moment, they're all having some financial distress.
Chelsea?
We saw similar trends at the University of Chicago as Dr. Harris. They put a priority on keeping all the staff, and they did decrease the salary for some of the people in the leadership positions so that we could maintain the staff there, which I think was really important in the long run. Yeah, we saw a huge dip just like everyone else. I think we were a little surprised at how quickly things kind of recovered, but I think we're definitely not out of the woods.
Rob, you're muted.
Obviously, again, we took a pretty big hit in the community practice realm, but we're able to offset that with the office-based procedures and the OBL stuff that we were able to do. If we didn't have that, it would have been much more difficult because, again, we were able to stay functioning and working and had some billable things to do. The hospital volume, ground to a halt other than the emergent work that we were doing. So I think we were fortunate having the outpatient office-based centers to do that. If we didn't have that, I don't know that we would have been able to maintain everything open the way we did.
Well, I can say that the Texas Vascular Associates experience was that if it wasn't for the CARES Act money and then the PPP money, we would have gone under in May. We would not have been able to make payroll by the end of May. As you know, in a privately owned practice, it's just hand to mouth. You don't keep a lot of money in reserve just to pay your bills. And at the end of the year, that has to be cashed out or it gets taxed heavily by the government. And so 2020 turned out to be an okay year for us, but only because of the government funding, just as Clayton has pointed out. And what we are seeing since then are more challenges in our revenue cycle. Since that money is no longer being pushed at us, and the beginning of 2021, we're busy, we're back at work, but we're seeing some significant disruptions in our revenue cycle. and it's creating some significant strains. And we're in the same boat as Michigan Vascular with the PPP money. We've asked for forgiveness. We've done all the paperwork, and it was quite an ordeal just to get in line to get that submitted and get it in place. And now we're just holding our breath, hoping that we will be forgiven, because if not, then it's going to add to our pain. Well, thank you very much, Dr. Brinster and Dr. Sternberg. With that, I'd like to move on to
Bill, it seems like
go ahead.
Well, I was just going to say, it seems like the restrictions in elective surgery are not as severe in the additional waves as they were the first time around. And is it fair to say that that's true, and that the financial impact of these subsequent waves has not been as great?
So I'd say in the second and third waves that we had at New Orleans, we did not have to stop elective surgery like we did the first time around, when it was a completely all hands on deck event. And that was part of that reason was we were able to build out an extra 100 ICU beds to help accommodate the COVID patients we were taking over 8 weeks, which was pretty remarkable. And so we expanded our capacity enough so that we could keep the OR sort of running and gunning. So that certainly helped our organization, I think, stay afloat.
We did have a decrease with the second wave where we had to stop elective procedures. We were able to still do urgent and emergent, so our division didn't get hit as hard as some of the other divisions, but because of lack of ICU beds and the increase in tide, they were concerned about that. So we did have another dip around December, January this past year.
We also noticed that some patients did not want to come in, or they delayed, what would be an elective carotid because of the issue of not wanting to go to the hospital setting for a procedure like that. So we saw some patient driven, we're not going to get care right now.
I would absolutely agree with that. I think a lot of patients have a lot of angst, and the family members also don't like it because they're not able to come in and visit with their loved ones after their procedures. So procedures that were more elective often would get postponed.
Well, I've had some patients that recently, since the vaccines have come out, have delayed surgery till they've completed their vaccination schedule. I don't know, have other people had that experience as well?
I've seen that some where people have been uncomfortable coming to the hospital until they're fully vaccinated, despite me telling them the reality is that it's probably the safest place in the community, which I think is true.
So Chip, you wouldn't delay elective surgery or recommend delaying elective surgery for someone to get fully vaccinated?
I don't think so. Because I think at least where we are in New Orleans, we really don't have a lot of COVID in the community. And I think the chances of someone contracting COVID in the hospital is even less than the community. So I don't think they're at increased risk.
Chelsea, what are things like in Chicago?
Starting to get warm finally. No, as far as elective procedures, I'm the director of the vein clinic at the University of Chicago, and we're pretty aggressive about getting back to work, even as early as May with those interventions. And I think as far as the vaccines, I wouldn't delay procedures, but I would emphasize that we could certainly reschedule, especially for the venous work.
Has anybody run into any vascular complications from a patient being vaccinated?
I've not seen that.
Not from the vaccine. I mean, we're seeing all kinds of vascular complications, but more from the disease itself.
It's interesting. I had one gentleman who has lupus anticoagulant and a bunch of lupus vasculitis, among other issues, and he's on anticoagulation, and the day after he got his second vaccine, he showed up at my office with a popliteal artery thrombosis. spontaneous. So it may or may not have been. And then I had another patient who had again, got his dose, his vaccine sequence. And when he came in for a surveillance CT scan on his endograft, there was thrombus in one of the iliac limbs. Now I didn't have a before and after, but it kind of makes you wonder,
Do vaccinated patients get any special treatment, if you want, or special privileges? They get to pass go without collecting $200 or whatever? Or do you not even ask them their vaccination status? Do they have a passport?
Well, I ask everybody, all my patients, are they getting vaccinated? But that doesn't really afford them any special privileges. We still have to do a COVID test on everybody before any procedure, irregardless of their vaccination state.
We're the same.
We're the same at University of Chicago, so no passport, and everyone still needs to get the COVID testing pre-procedure.
We've actually got a mixed bag. One hospital requiring COVID testing for everyone, two of the hospital systems not. We personally have been requiring it before elective procedures that might be admitted to the hospital. But it's been somewhat difficult to get at times too. At times we'd be able to bring a patient into the hospital for a same day admit and get a stat COVID test that morning. Though they've stopped that, they won't allow that anymore. So it's made it a little more difficult.
Yeah, what's the time frame from the test to the procedure that are being used at the different systems y'all are in? Is it same day, day before, 2 days before that the test has to be done? 3 days?
At Oxnard, it's got to be within 3 days.
Ours is within 5 days. A lot of the patients have it done the same day.
Mm-hmm.
Ours is 2 to 3 days before the procedure, and then there's the stat if we need it the day of.
Has anybody had to cancel a procedure because of a positive COVID test?
Yes.
Did the patient actually have COVID, Dr. Harris?
Actually, in the last one that I had that happen, the patient was coming for an outpatient procedure on an access, and the stat test came back positive. We sent a regular test the same day, and that was on a Friday. We brought him back Monday because the regular test was negative. So the stat test was a false positive.
Yeah.
Bill, without switching the screen over to the chat screen, because that's a little bit clumsy, let me just tell you, we've had a chat come in asking whether academic centers should develop OBLs to help offset clinical volume, teaching volume, and maintain fiscal solvency. Is it time for the academic world to get into the OBL space?
Well, I think Dr. Brinster, Dr. Sternberg, would you like to comment?
Well, I think it's a very interesting question, and I think the answer is probably so. And our own institution is creating an OBL of sorts. It's kind of going to be a super OBL, or a clinic that has more than just procedural areas, but it's going to be completely outpatient based. And that's going to be up and running probably in about 18 months or so. But I think that I think there is really opportunity for traditionally academic places that don't have OBLs to utilize them, because clearly there's a good area for patient care that can be done outside of the hospital, and this whole pandemic has exposed one of the really good things about OBLs.
And Dr. Harris, what about in Buffalo?
We're actually in the process of trying to partner with the institution and with a couple other specialties, and they're supposed to be building a large office center that will have an OBL. It's underway, but the COVID situation has actually delayed things because of finances. I think for academic centers long-term, I think it does make sense. The OBLs certainly can bring in some money, more than some of the inpatient procedures and outpatient in the hospital, and often are much more efficient. The patients like it better because they're more efficient. So I think that's definitely a way they should be going.
And Dr. Dorsey, is your vein center, is it in an outpatient kind of environment? Would you call it an OBL?
I wouldn't necessarily call it an OBL, no, but we have a couple offices at locations outside of our main campus that we do some procedures, but I wouldn't categorize it as an OBL.
I would encourage everyone that might be interested to get with the SUVC. I mean, we've got a lot of momentum and we're trying to really build what would work for a lot of people within the SVS. And I think there's lots of different areas. I know I had a conversation yesterday about the area where there's deserts of care or lack of care, either due to rural locations, et cetera. And an OBL type setting where with the shortage of vascular specialists that we have might be a good way to do that, where there's a OBL type center. We could have advanced practitioners that work with us, and then providers come out, 2 days a week, but at least provide vascular care in areas that are underserved. And that might be a good extension to look at going forward.
I'm sure we'll have more to talk about the role for the OBL in the COVID situation, but Bill, you want to go ahead and introduce Dr. Dorsey to keep us moving here?
Yes, sir. It's I'm honored to. Dr. Chelsea Dorsey is faculty in the section of vascular surgery and endovascular therapy at the University of Chicago. She serves as the ambulatory medical director for cardiac, vascular, and thoracic surgery, as well as the director of the University of Chicago Medicine Vein Clinic. She graduated from the University of Chicago Pritzker School of Medicine and then completed her vascular surgery integrated residency at Stanford University School of Medicine in 2015. And as an aside, in my discussions with Dr. Dahlman, he described Dr. Dorsey as a rock star. Beyond her clinical responsibilities, Dr. Dorsey is passionate about medical education and creating diverse work and learning environments inclusive of all. In keeping with these interests, she was appointed the Director of Preclinical Advising in the School of Medicine in 2019, and she also chairs the Department of Surgery Diversity, Equity, and Inclusion Steering Committee. Last month, Dr. Dorsey was an invited speaker at the Midwestern Vascular Surgical Society webinar focused on digital technologies and virtual healthcare. Her talk was entitled Telemedicine for Optimal Patient Care. She hopes to build on that talk today as we explore the next steps in our telemedicine journey. And then one interesting fact about Dr. Dorsey, she once ran into Michael Jordan at a movie theater and can only think to ask him one thing: are you Michael Jordan? So thank you very much for that fun fact. And Dr. Dorsey, the floor is yours.
Awesome. Thanks so much for having me. I did pay Dr. Dahlman to say that. So, so we're going to get through a lot here in the next 15 plus minutes or so. So we'll start with kind of a brief refresher of kind of the terminology around telemedicine. We'll talk a little bit about the kind of satisfaction levels from a patient standpoint, and then from the provider standpoint with telemedicine. Then we'll switch gears and kind of think about things at the ground level, what's going on with vascular surgeons in practice, what are the positive things, what are some things that aren't working as well, or some potential pitfalls with telemedicine. And then we'll talk about future state. So we'll kind of grapple with that existential question of kind of where do we go from here with telemedicine. I have no disclosures for this talk. All right, so this is just kind of a quick review of things. So telehealth is kind of that umbrella term that's used to describe essentially 5 different categories of virtual care. So that includes mobile health, virtual check-ins, it includes remote patient care, wearable technology, and then it also includes telemedicine. Telemedicine encounters are basically those that are happening between patients and providers using some kind of audio visual technology in kind of a real-time setting. So this category is then further broken down into video visits where you have patients at home, and then telemedicine clinic where you have a patient at an originating site. So they could be at a small clinic in a rural community. And then you have the provider who's at a distant site. So they could be at a tertiary care center many, many miles away. So in general, telemedicine, I would say, was definitely underutilized prior to COVID-19, and that was for a number of different reasons, including access issues, problems with inadequate reimbursement, but there's clearly benefits to telemedicine, and we saw that a lot during the public health emergency. So just having continuity of care with patients, having the ability to use less PPE, and then obviously reducing the risk of exposure to patients and providers to coronavirus. And then, as we can all attest to, all these kind of telehealth services and programs were really rapidly expanded and integrated during the pandemic. So this next slide here is basically just kind of taking a look at a summary of what we saw with the CMS changes during the public health emergency that really allowed telemedicine to expand. So what you can see is we really went from using telemedicine pre-COVID in a very limited fashion with primarily established patients. And it was basically in that telemedicine clinic format. So you had patients at an originating site and providers at a distant site. And it was really with very specific platforms that were used. We went from that pre-COVID to what we see today, where we can really do these telemedicine visits with any E&M visit. We do it with established and new patients. We can do this with patients through video visit where they're at home, or they could be at some other site. I've had some awkward interactions with people at different sites. And then we've been able to use any platform basically that can get the job done. So, perhaps like many of you, I was very hesitant at first to kind of jump into telemedicine. I was a little, reluctant to have to add something additional to my ambulatory workflow. But hopefully what you saw over the course of the pandemic, and as you were kind of integrating telemedicine, is that you start to get into a routine with it, and it actually it works pretty well. And I bet you had a lot of patients that really had positive experiences from a telemedicine standpoint. So I'm going to spend the next couple of slides going through some of the data, exploring kind of what patients and providers' satisfaction level was with telemedicine. So this first study was a retrospective review of telemedicine interactions in the Mayo system, specifically looking at their vascular surgery practice. So this included over 6,000 patients, of which 790 had telemedicine visits. And they found that patient-reported satisfaction remained unchanged with virtual visits. This next study here was actually an integrative review looking at patient and provider satisfaction with telemedicine in a number of different disciplines. So they included data from about 18 different studies and found that overall patients and healthcare providers have high levels of satisfaction with the use of telehealth. And many reported a willingness to continue to use that technology after the pandemic. This last study here is in the neurosurgery literature, and similarly found that most patients and providers report positive experience with the use of telemedicine. And we're going to spend a little bit of time looking at this study because I think they actually did a really nice job of thinking through some of the finer points when we think about the use of telemedicine. So over 60% of providers agreed or strongly agreed in this study that a patient's clinical needs could be adequately addressed with virtual visits. Notably, nearly a quarter of respondents had a neutral response. So the vast majority of these providers felt like these encounters were going, well. In addition, over 80% of the providers felt that the level of communication was appropriate during these telemedicine visits, and most wanted telemedicine, further integrated into their practice. So this made me feel better. These were some of the things I was concerned about when I was starting to integrate telemedicine into my practice. When we look at the patient side of things, over 90% were satisfied with their telehealth visits and felt that their provider addressed their clinical needs. Furthermore, nearly half of the patients actually preferred telehealth visits over in-person visits. The responses to the survey also suggested that there was perhaps an opportunity for more engagement with the patient during the virtual visit. So in this study, only about a quarter of the patients stated that the provider attempted to examine them via Zoom, and only about a third of the patients stated that the provider showed them their radiologic findings over the shared desktop. So again, I think an opportunity for us as providers to think about how we're using these platforms and making sure we're kind of maximizing things. We're really using the technology so that we can show the patients their imaging, and also, even though it's awkward, trying to examine them in some way if possible. So I'm gonna switch gears a little bit, and I wanted to think through, what does this look like for vascular surgeons on the ground? And so, I decided to ask my partners kind of what they thought, and overwhelmingly, really, we all were pleased with the addition of telemedicine, and we generally felt that it expanded our ability to provide care to patients. So this is Dr. Skelly. He's our section chief, and he's also one of the world experts when it comes to the treatment of median arcuate ligament syndrome. And he was particularly pleased with telemedicine. He said it allowed him to reach patients he may have never been able to see before. In his own words, he called it a game changer. And he went on to say that he could finally meet, patients and evaluate patients in remote regions, those who cannot afford the cost to travel for an opinion. So he's one of, very few people who really focuses in on this disease process. And he usually has people fly in to get his opinion, and now he could meet with people that normally wouldn't necessarily be able to access him, which is great. So then there's this guy. You guys probably know Dr. Molinar, bit of a wallflower, right? So I asked Dr. Molinar kind of about the benefits of telemedicine, and he stressed patient-friendly aspect of it all. And he really liked the inherent flexibility of telemedicine as well. And what he doesn't say in this quote, but I know to be true, is that Dr. Molinar really took advantage of telemedicine's ability to allow doctors to be in multiple places at once. So for some of his offsite clinics, he converted them to completely telemedicine clinics. So patients at the originating site, they're at this offsite location. He's at the main campus, the distant site. They would get their surveillance AAA scan, their carotid scan, ultrasound, and then he'd be able to talk through them, talk with the patient and have a visit. So this was really important over the course of the pandemic, and I think moving forward still, largely because of that last line of his title there. So Dr. Molinar is the Vice Chair of Clinical Affairs and Perioperative Services, which basically means he handles much of the clinical affairs in our Department of Surgery, and he kind of runs the OR. He also was, largely helping to lead our response to COVID in the Department of Surgery. So it was really critical that he was at the main campus. He was kind of vital to the flow of our workflow in the Department of Surgery. So I know that this kind of model for him was really effective and allowed him to be a little bit more flexible with things. So in my practice, I continue to include kind of designated telemedicine slots in my template. I put them at the top of my clinic so that if there are technological issues, that it doesn't totally interfere with my in-person visits that are scheduled. What I've also started doing, so as I was saying, I'm the director of the vein clinic, and we're trying to expand to a bunch of different offsite locations. So I've kind of integrated telemedicine into the follow-up process, which has been really nice. So I go out to this clinic, for instance, in Orland Park every other Friday. It's 30 miles from our main campus. And I see patients in the morning on Friday, and then I do procedures in the afternoon. And then, so for the follow-up visit, I have patients come back to that originating site in Orland Park. They get their ultrasound to check for DVT, and then they do either a video visit or a telemedicine clinic visit with my nurse practitioner later in the day. And that is really great for the patients because it's convenient. And from the provider standpoint, it's just really nice. I mean, I'm not as important as Dr. Molinar quite yet, but I do wear a bunch of different hats in the hospital and in the medical school. So it's nice to not have to be driving all over the Chicagoland area, and I can still take care of my patients. So I've been talking a lot about kind of what's great about telemedicine, but I would be remiss if I didn't talk a little bit about the spotlight that was placed on access issues during the pandemic. Telemedicine has been incredibly helpful during the public health emergency, but we have to remember that there's the potential to both diminish and widen health disparities with the use of telemedicine. We could see this almost right away when we, implemented or integrated telemedicine. So with under-resourced populations, when we looked at the Medicare and Medicaid visits for these patients at the top of the pandemic, they plummeted. So for patients who were older, or patients who don't speak English, and just generally with Medicare and Medicaid patients, the number of visits went down significantly when you compare them to the other groups. So we just have to keep in mind that things like broadband, smartphone access, it's not universal, and it varies significantly depending upon race, ethnicity, age, education, income, location. If you take something like broadband, so suburban homes in the United States, 79% of suburban homes have broadband. And you compare that to rural homes in the United States, it's 63%. So it's significantly different. So these are things we have to remember. So I ask all of you to kind of burn this image in your head, be thinking about this as you're formulating your telemedicine plans. Think about ways to mitigate digital literacy issues and barriers for people with disability. When you're thinking about your telemedicine clinics and your patients, you have to assess all the needs of the patient. So the medical needs, the technological needs, the cultural needs, the linguistic needs, all of those things. And then obviously keep in mind or refresh your memory on federal, state, and local policies as it relates to access issues for your patients. And then always ground your telehealth plans in principles of health equity. So you want to really center marginalized patients in the development of actionable solutions. So, the real question is, what is this going to look like for us in the post-pandemic world? In our practice at the University of Chicago, we really utilized telemedicine heavily at the beginning of the pandemic last spring and into the early summer. But the reality is that we really settled back into a stance of really not using it as much as I think maybe we should, especially given the data I just talked about satisfaction levels from both the patient and the provider. I'm early in my vascular surgery career, but one of the things that I was drawn to, and one of the reasons why I went into this field, is because we have shown an ability to grow, to adapt, and to incorporate technology. And we did that in spades with our aortic work and our PAD work. And I'm really curious to see if we do the same with telemedicine in the future here. So I just have a couple more slides. So one way to think about this is through a value-focused lens of how healthcare should be delivered. So this specific value equation was taken from the University of Utah, and they define value. I'm going to read this because I want to get it right. They define value as the product of the quality of care plus the patient experience at a given cost. So in other words, value is a composite of the shifting relationship between levels of quality, service, and cost in the provision of healthcare. And actually, I think the most important word there is shifting. So I think we have an opportunity right now, as we've learned over the course of the year, what we've done with telemedicine through the pandemic, to really address some of the shortcomings of in-person visits. So thinking about some of the inefficiencies of in-person visits, thinking about some of the inequities. I think we have an opportunity here to kind of up the value of the care that we're providing. And I do want to thank Dr. Hull at Northwestern. He let me borrow this slide. We both presented at the Midwestern Vascular Surgical Society last month about telemedicine, and he threw this up there, and I thought that this was a great way for us to be thinking about this moving forward, especially if you're going to be in meetings where you're talking to stakeholders. This is, I think, a great way to think about it. So just a few final thoughts here. So, telemedicine is a pretty exciting healthcare delivery tool. I think it's been really helpful during the pandemic. In large part, as you could see by the research, providers and patients generally like this mode of care. There are multiple ways or examples of how telemedicine can expand your practice with its flexibility, how convenient it is, and the ability to access patients you might not have been able to see before. But we do have to keep in mind that there's the potential to widen equity gaps with telemedicine. And I think we all just need to kind of think about what we want this to look like in the future for vascular practices. Based on a lot of that data, which again shows satisfaction, I think that will drive things. There's going to be a demand on the patient side in the future here for us to continue with telemedicine. So I think that means a lot of those CMS changes are going to stay around. So we just have to figure out how we want to approach this as a specialty. Thank you, and I'm happy to take any questions.
Well, thank you for a very terrific presentation, Dr. Dorsey. That was very illustrative, and admire your ability to organize your telemedicine practice. We had the same experience as you did, and apparently all over, a lot across the country. I read just the other day that in April 2020, something like 16% of all of Medicare expenditures went just for telehealth. Now that had dropped down to 5% for the third quarter, but clearly it's a very valuable part of what we can offer. What I found in my own practice is that my staff are comfortable scheduling in-person visits. That's just kind of their mentality. It's easy for them, and I'm having to push back a little bit and say, no, let's do this tele. How are you working with your people to get that televisit module working?
Yeah, I think there's definitely a learning curve with it, right? So there was definitely I had some resistance at first about doing it. But I think as people just start to do it more and more, you realize that it can really be integrated pretty easily into your workflow. We use a platform that's integrated into Epic. And then we use kind of Doximity as a backup if patients are having problems. And I think our staff liked that there's kind of two different options if they're having problems. The Doximity, I've used that as a patient too for my girls for a pediatrician visit. So that's pretty easy too. They just send you a text when you're ready to have the visit with the provider. So they've made it pretty easy to use it. It just, again, there's a little bit of a learning curve initially.
Yeah, no, terrific. I have some more questions for you, and there's some text to chat questions regarding telemedicine as well that we'll bring up later. But in the interest of time, we need to pivot to Dr. Harris' presentation, so make sure everybody gets an adequate time, and then there'll be some time left for more questions for the broader panel discussion. So thank you very much, Dr. Dorsey. And now it's my pleasure to introduce Dr. Linda Harris. And she is a tenured professor of surgery at the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo State University of New York. She's the program director for both the 5-2 traditional fellowship for over 20 years, as well as for the 05 vascular residency since its inception. She has led the Division of Vascular Surgery for 2 decades. I did not know that. 2 decades. Congratulations. She completed her vascular training at the University of at Buffalo State of New York in vascular surgery in 1995. Dr. Harris is nationally and internationally known for her work in the field of vascular education, having served on the ACGME Surgery Review Committee, the original Vascular Surgery Milestone Project, and as the past president for the Association of Program Directors in Vascular Surgery. She is the past president of the Eastern Vascular Society and has been involved with multiple SVS committees, including serving on the Strategic Board of Directors and the Education Council of the SVS. She has served on multiple editorial boards, authored numerous papers and book chapters in all of the major vascular texts, and is a co-editor of 2 recent vascular textbooks. She would like me to invite everybody that's watching this webinar to join her tomorrow at the 2nd Annual Women's Vascular Health Summit virtual meeting this year at 1 p.m. Eastern Time. Registration is still open at womensvascular.org. The meeting is primarily designed to address how sex impacts vascular disease presentation, intervention, and outcome. And this is summit has been endorsed by the Society for Vascular Surgery. And one interesting fact, now I don't know if her astrological sign is Aquarius, but she's a water enthusiast, loves swimming, fishing, both inland lakes and deep sea, scuba diving, water skiing, and tubing. And I'd love to see pictures of some of your best catches, Linda. Thank you very much. And now the floor is yours.
Thanks, Bill. And I'd like to thank Bill and Kim for asking me to speak. We're going to pivot a little bit from what we've been talking about to look at the impact of COVID-19 on the surgical education. And the question is, have we lost a year? Those of you who are parents, which would probably be many of our faculty and many of our trainees, have seen the impact on our own families from young children in preschool through high school and college, with a lot of lost time, and how the remote learning has really had a major impact. And clearly it's had an impact on our medical students, on our fellows, and our residents as well. So we're going to look at a couple different areas. With medical students, they had time that they actually physically missed where they were not allowed to be in training whatsoever. 3rd year and 4th year rotations have been changed. They lost some internships. They lost the opportunity for away rotations, interviews more significantly, and of course their well-being was impacted. For our fellows and residents, we had issues with major change in didactics. Clinical experiences changed significantly. Research and presentations also had some major changes. Interviews and job searches have changed significantly, and there's concerns about well-being, and the board exam also changed significantly during the past year or so. So just briefly going over the timeline as to what's gone on, these are mandates and recommendations that have impacted education. So in March of last year, WHO declared a global pandemic. Very shortly thereafter, as we've already heard, the ACS recommended cessation of all elective cases. That was March 13th. We, of course, had our own vascular recommendations of when to decrease and what type of cases to perform. The AAMC suspended clinical activity as of March 17th of 2020. So that's when the medical students went out. Now, positive changes, the ACGME allowed for direct supervision for telemedicine, and also remote supervision was allowed to occur as of March 20th. And that's important for education because we are responsible for supervising our trainees at all times. CMS then followed by saying we're allowed to directly supervise virtually in April 30th, so that way we could get reimbursed for what we were doing in a remote fashion. Then, of course, we have the epic fail of the general surgery QE exam in July of 2020, which resulted in a delay in all of our exams in vascular surgery as well. And then in August of 2020, the medical students returned to some clinical activity. So how did vascular surgery react to some of these changes? Well, the APDVS, our organization for program directors, has had virtual meetings the last 2 years. There were recommendations that came out of the APDVS leadership that we should not have any sub internships. That was consistent with the Coalition for Physician Accountability. That began last year. And finally, this coming August, we're going to be allowed to have some remote or some away rotations once again. They discouraged away rotations at that time and recommended we be flexible in the type of letters of recommendation, because without those away rotations, that made an impact on those letters as well. They ended up eventually recommending only virtual interviews. This impacted actually the fellowship interviews last year, where some of them had been in person and some were forced to be virtual as the changes occurred right during the middle of that process. Residency interviews were completely virtual this past year. With all these changes, we then had about 6 or 7 programs across the country that developed virtual sub-internships. Now, what was a virtual sub-internship? It varied significantly between the different programs. Some of them were 2 weeks, some were 4 weeks, some had a great deal of interaction, some were more just watch a few conferences, so they varied a great deal. They are going on again this year, but how much attendance they'll have, we'll have to wait and see. The Vascular Board also made some differences. They allowed off-site educational time to count as clinical time. In the past, that would not have counted. They allowed a decrease to 44 clinical weeks for the graduates in 2020, and that'll again be the case for 2021. They allowed for a 10% decrease in the total major cases that were accepted to 225. There was no change in the major defined categories for the required cases, but for the total major cases. And of course, the program directors still have to assess for readiness for independent practice. The exams again in last year were canceled. The CE from 2020 was canceled and then eventually was performed in January 2021 virtually with great success. The QE was postponed and occurs in May of this year, and the CE is planned for July. So there were some scoping reviews of the medical education literature to look at what's been the response to COVID-19. And again, like a lot of other areas, there's been an explosion of research, not just clinically, but with the educational part. There were over 127 studies. Over 40% of them were related to the medical education, so the medical school portion, and 32% were related to residency and fellowship. Interestingly, the vast majority of those were in general surgery or surgical subspecialties because of the technical implications for our trainees. It's also been a huge opportunity to rethink the global cooperation, education, and research, and there's been a lot of sharing of how to handle the didactics in a remote fashion. So what are all these studies about? The vast majority have dealt with the pivot to online learning, as we've all been doing more of these remote Zoom and WebEx and RingCentral, everything else. The vast majority of our online learning has been synchronous, meaning real time. We're here, the trainees are there at the same time. We've been learning to use chat boxes, breakout rooms, polling quizzes, and games to increase some of the interaction. There are a lot of positives that we found with this hybrid model or the remote model, and that includes improved attendance, flexibility, convenience, and less travel time. But there are some major disadvantages, which is the loss of social interaction, passive participation, or people who pretend to be there but aren't really there, distractions at home, communication challenges, the Zoom fatigue, as well as cyber threats and security issues, internet connectivity issues, and again, it's more difficult to teach and assess any sort of technical skills remotely. And additionally, we need additional administrative support to make this work. Simulation training has also been altered during this time of the pandemic. Less of the technical skills have been able to be done, but there have been some teaching of technical skills like use of PPE, and more of that has been multidisciplinary. Assessment has changed to more open book exam type features, and there's been more remote proctoring, which we didn't have in the past. Other studies have looked at well-being, telehealth, clinical service reconfiguration, the interview process, service provision, and also faculty or professional development. So looking at a survey of general surgery residents with over 1,100 respondents, they did find that the majority of respondents were in the areas of higher COVID infections, such as New York City and California. So this may impact some of the results. But they did find that 77% of clinical duties were being delegated to physician extenders. So more of the residents were delegating to the extenders rather than doing some of the work themselves. Having said that, a quarter of the individuals worked greater than the allowed 80 hours per week during the pandemic. 80% also had absolutely no clinic time during the pandemic. Education, interestingly, there was a 41% increase in didactics, and over 80% had completely virtual didactics. Despite all that we've been doing, wellness was an issue. 33% felt more burned out than usual, with 72% having concerns of transmission to their family and friends, and 55% concerned about contracting COVID themselves. 42% were concerned about not meeting the case minimum requirements. Now, we don't know whether or not this is going to come to bear yet, but that was certainly a major concern from the trainees. During the peak of COVID, the OR participation was a major problem. 40% of individuals were excluded from the OR with what they called high-risk COVID transmission cases in the beginning. 12.5% of junior trainees were completely excluded from the OR for a period of time. There were 35% of individuals who had no cases in at least 1 week of the studies, and 45% had only 1 to 3 cases. So what about vascular education? Again, we see issues in clinical, in teaching and research, well-being, as well as in career planning. So where they're going after they finish their training, as well as recruitment to our field, which has been a major push of the SVS as well as the APDVS. So clinically, during the peak of COVID, we had fewer trainees in the hospital. So we know when the pandemic first started, many of us did split rotations and shifted people were redeployed to other services, but we were trying to decrease exposure. So there weren't as many trainees on a given service at a given time. We also have fewer trainees on rounds or in procedures. There was less teaching from resident to resident or fellow to resident or resident to student. The change in the clinical caseloads also saw a decrease in elective cases and many more emergent or urgent cases. So more amputations, fewer open abdominal cases. There was definitely a major decrease in clinics experience. Part of this is related to what you heard in the last talk, which is the shift to telehealth. We're learning how to do telehealth, and we couldn't figure out how to do it ourselves, let alone how to incorporate trainees into the telehealth process. And in the beginning, we weren't sure that if they were involved in telehealth, that we would be reimbursed or that we would be covered for supervising them. Clinical case volume, again, there was the shift to the emergent. The ABVS did allow for 10% below the minimum requirement for the total major cases, but we still had to do the rubber stamp that they were competent to practice independently when they graduated. So you might say, was there really a change? I looked at the ACGME numbers from 2018 through 2020, and interestingly, when you look at the different categories, there was really not a major decrease anywhere except for venous and access across the board over the last several years. Now, what we have to remember is the graduates in 2020 were only impacted for about 3 months. So the changes we're probably more likely to see in the 2021 graduates and those individuals going forward rather than the 2020. Many of the 2020 graduates had already met all of their minimum cases, and so it was not an issue for them. But when you look at, again, the 2020 graduates, now one of the problems with the ACGME is they've changed how they present their reporting. So they were not able to give me the 2017 to 18 graduates minimum defined cases. But if you look here, both the fellows and residents had no problem meeting their numbers. The area where the American Board of Vascular Surgery said we could decrease numbers, interestingly, from 2017-18 to 19-20, our trainees all increased. So they went from 400 in the fellow to 441, and for the residents from 485 to 675 cases. So the 2000 and the 2020 graduates did not have a decrease in their major cases and had no problem meeting the numbers. We will have to see whether or not there's a major impact in 2021, and those individuals have had really a full year plus of some level of decreased cases and are more likely to have issues there. So what about teaching? Our teaching has had a major change, which was the shift from didactics that were almost always in person to the virtual format. Initially, there was often a brief cessation of didactics. We experienced it ourselves. Some of those shifts occurred because of lack of knowledge of how to use technology. The other issue were higher stage COVID infections with redeployment and those type of issues. But what we have found is it definitely allows greater participation. And initially then, after the high risk of COVID and the high rates in the redeployment issues, we had more time for didactics when there was less elective cases going on. There have been a decrease in visiting professors initially because people weren't going to visit, but now people are doing this remotely as well. Simulation has decreased in some ways because cadaver labs initially were not allowed to be done. Simulation that was brought by industry could not get to the different institutions. Again, this is starting to increase once again back to normal levels. There's also been less ability for residents to teach because there weren't students on service for a while, fewer junior residents in service, fewer people going in on any given case. Again, this is starting to shift back towards the norm now as where we were before. Research, well, here's actually a positive. Research saw a major surge during the COVID pandemics. We had increased time for people to be able to do research. It was great for database type research, not necessarily ideal for basic science or hands-on where people couldn't necessarily be on site to decrease the risk of transmission, but a great opportunity. On the downside, there was decreased opportunity for the trainees to present due to abridged meetings that were virtual and often relied more on the faculty presenting. There was an explosion of articles on COVID and vascular disease. There were over 600 since the pandemic began. In our own journals of vascular surgery, there were 66. European had 10, and Annals had 29. And then if you want to look at education type research with surgeon or resident well-being and burnout in COVID, there were over 100 articles there as well. Well-being has been a major issue for our trainees. When you looked at some of the surveys, they found that 30% of New York City trainees missed at least some time. 75% of those missed more than 2 weeks. There was concern about impact on physical safety for trainees, emotional health, as well as for health of the family and risk of transmission to the family. There's been a lot of stress over dealing with severity of deaths in what we would think of as healthy patients. We're used to dealing with death and injury, but most of our patients tend to be elderly and sickly. Here we were seeing young, healthy people come in, losing limbs, having strokes, and issues that we couldn't fix as easily. Burnout and social isolation, again, were major issues for the trainees. So career planning is another issue that we've had a problem with. And this goes both for our trainees who are graduating as well as for our ability to recruit to the field. We've had a major push for the last several years because of concern that we don't have enough vascular surgeons. And now with the pandemic, we couldn't get people doing away rotations. So people who came from programs that didn't have vascular surgery couldn't do that. In addition, when they had the pause for medical student education, the medical students have now had to catch up. And so they've had less opportunity for some of those elective rotations. The trainees who are graduating last year also had issues with places that wanted to hire, had opportunity to hire, but then had a freeze on hiring because of the financial situation of the institutions. In addition, many of the times the graduating trainees would be meeting their prospective new partners at national meetings and regional meetings, and that again was gone. So now everything has been virtual. More recently, people have been able to travel a little, but that's also impacted our trainees. So where are we now? Well, our interview process likely has irrevocably changed. We've definitely seen some major benefits for the trainees, particularly with less cost, less time issues. For the programs themselves, there's also less cost. Overall, people have liked it well. The question is going to be whether or not the individuals we've all matched do well in our programs. But likely the virtual will at least be a part of our future interview process. Clinical experiences, we expect case volumes will likely be down for the 2021 graduates. That's yet to be seen though. Didactics had a significant improvement with the digital and hybrid modality that is not likely to go away at any point in the near future. Research has actually done well, and we expect there to be more opportunities for the trainees to present in this coming year. Well-being remains a major issue and something we need to be cognizant of for our trainees. Recruitment and career planning has been a problem with the decreased ability for away rotations. It's again opening up in August, so hopefully we'll be able to help continue to encourage people to the field. There have also been lost experiences, and the confidence level of some of the graduates may be impacted. We haven't seen that yet, but that's what we need to watch out for, is whether or not these individuals who are graduating in the next year or two are going to have the same confidence. Will they have the same volume of cases in some of the complex procedures? Again, 2021 graduates did not see a volume decrease. We don't know about 2020 yet. And again, there's been a lot of increased opportunity for collaboration remotely, as we've all discovered how to use the internet in many different fashions. So I'm going to finish up right there.
Well, thank you very much, Dr. Harris. And I ask you nicely to please stop sharing your screen. There you go. We're going to go to a panel format. And I have one question to follow up on your talk before we move into our panel discussion to finish up. What do you think has been the most positive change from all this in training and education? And do you think this will be permanent or just temporary?
I really think the most positive change has been the hybrid model for didactics, because we really, before this, most of us were in person. We were all old school. We like to get together. And while it's great, and I miss all my friends getting together, the extra hour a day to drive to a hospital that's not the hospital you're operating at, or you're not working there because you're supposed to be in a clinic, meant that people didn't always attend. And now this has given people the opportunity to really be present for conferences on a regular basis. There's often no excuse not to be there. So it's much easier for people remotely to participate. We can share information, the screens, the images is very easy. I don't think that's going away anytime soon. And I think even with our national and regional meetings, we're going to have some sort of hybrid that's going to be there, which will allow people who can't be there for the whole meeting. If you can come to the SVS and only be there for 2 days, but you have an obligation back home, you can participate remotely for part of the rest of the time. So I think that part is probably the strongest thing that's come out of this pandemic in a positive note.
Yeah, doesn't look like we'll be going back for sure. We have some questions from the chat. This will be for all of the panelists. This was a good one. What plans do the panelists have to maintain their practice if another severe pandemic surge occurs? Do you have contingency plans? And if so, what are they? Rob, would you like to start with that?
Sure. Yes, We will plan to stay open. I mean, our contingency plans are to be as proactive as we were before. We successfully weathered it last time. If things get really bad, I think we've got a great COVID response team in place. We've got protocols in place. Again, we do have 3 hospital systems we work at. And so our plan will to be there, and our office-based procedures will probably be maintained as well.
I'm just going to go around the room. I imagine everybody feels pretty good that there won't be a surge like there was a year ago, but perhaps if these mutations do turn out to be vaccine resistant and we do get as bad as it was a year ago, we could be in the same situation. Dr. Dorsey?
Yeah, I think that the second surge that we had was kind of a pilot for that, and we took a different approach, as Chip was saying too. So we kind of went full throttle for the most part in the operating room with elective procedures. We used the MENTS scoring system, which was developed at our hospital to help kind of prioritize which patients should go during those big surges. So that proved to be very helpful.
And then next would be Dr. Sternberg and Dr. Brinster.
I mean, I think that with every surge, our hospital has become more savvy in how to adapt. And in the first surge, many of our vascular staff were working COVID ICUs, and in our second and really our third surge, instead of us doing that, we started actually admitting patients that traditionally would be admitted by the medical service. We were taking care of so that the internist could take care of the COVID patients. And we were able to do that and still not close down the OR. And so we have enough capacity now that it would take a massive surge for us, I think, to shut us down.
Dr. Harris, how about in Buffalo?
I think the biggest issue that's going to limit anything we do is really the ICU bed. So that's the only type of patient that might have a limitation, is if the ICUs again become overwhelmed. We've gotten a lot better at taking care of the COVID patients, and I don't think there'll be a problem there. But that was the only area of concern with the last surge we had, that we had to decrease patients who might potentially need an ICU bed. Everyone else was no problem to continue operating. The hospital doesn't want to lose money the way they did before. We don't want to stop caring for the patients who need intervention. So it's really the patients who might need a critical care bed if your ICU beds are being overwhelmed with another surge.
And another question from the audience: is there any support for surgeons at your institutions or practices for wellness, anxiety, and burnout, given these disruptions and financial strains? What are coping strategies the panelists are utilizing? And I'll start with you, Dr. Harris.
Well, the institution actually has set up a number of different opportunities. They have hotlines available, which they've made very well known for both faculty and for trainees on a regular basis. There are a lot of different webinars about coping skills as well. So there are a number of different things that they have set up. I think the biggest thing, at least that I look at from the trainee and from faculty standpoint, is working together with each other and making sure that everyone's feeling supported. It's a stressful time for everyone. There was isolation and social distancing. Your financial status was in question. So there are a lot of concerns for everybody involved. And realizing that you're under stress is the first part, and accepting help from others is important.
Dr. Molinar, I guess you have a couple issues, because you've got your group practice and your colleagues and your partners, and then you've got your employees, but then you're also affiliated with Michigan State. So
yeah, we've got actually one of the hospital systems has done a good job with a wellness program, and actually it started almost 2 years ago, a wellness survey that's sent out every 6 months. So they've tried to engage proactively on some of the wellness issues and burnout and the stress that's just incumbent upon what we do. The residents, I also am a assistant program director for the general surgery residency. And, I was really proud of the fact of what they did during that time, especially during the first pandemic, because, they were really called upon to provide a lot of service, and they proactively said, hey, let's start the line service, let's do this. So, they really did a nice job with that. And I think they were well prepared to take some of that stress, but we made it very abundantly clear that there were avenues, and there's, hotlines, and a lot of attention is paid to the wellness of the staff, the hospital employees, and of course we do with our staff as well in the office.
Dr. Dorsey, how is this dealt with at the University of Chicago? What kind of support do you all get?
Yeah, we have, I would say, pretty comprehensive list of resources for both faculty and trainees when it comes to wellness. We also have a hotline, so someone who's available 24/7 for people to speak with. Over the last year, we've also kind of done a lot in our Department of Surgery as it relates to diversity, equity, and inclusion. And with that, one of the subcommittees within that focuses on ethics and wellness. So we've done a lot kind of specifically within the Department of Surgery too, to try to kind of improve the environment overall.
And then Dr. Brinster and Dr. Sternberg at Ochsner, have they doubled down on their wellness efforts to help the faculty and trainees, staff?
Yeah, I think at Ochsner is, I found to be, since I've been here since 2015, fairly proactive in that arena at baseline. And I think during the pandemic, the administration has interacted pretty facilely with the staff and the faculty to maintain that going forward. Like others have echoed, a series of webinars. There is a phone number. There are emails that come out every so often, less frequent now, but still emerge for staff recognition and support. And similar to what Dr. Dorsey was describing, we have within the past year formed a diversity, equity, and inclusion committee formed of residents and faculty for just that reason, to not only address those cornerstone issues, but also to aid in wellness through the pandemic.
And I have a question for Dr. Dorsey about telemedicine, and this is kind of a personal one. When I'm doing my telemedicine and everything's all set up and my MA tells me, oh yeah, they've got the connection, whether it's Doximity or Haiku or whatever we're using for that particular visit, and then I get on and it doesn't work. What are your tips and tricks to get a quick workaround to get it fixed so that you're not spending too much time with the technology and less time with the patient?
That never happens for me, so I'm not sure what you're doing over there. So I guess some things you can do, definitely like scan your clinic list beforehand, because you might be able to identify people beforehand who might have an issue or might not have kind of the technological capabilities to do the telemedicine visit. We have it set up so our staff connects with the patient well in advance of my actual visit with them, so they can do a lot of the troubleshooting. And we have designated people kind of throughout our outpatient facilities who you can go to if there's technological problems. But I think always having a backup plan is probably the best way to go too. Like I said, we have an integrated system within Epic through Cisco, but when that doesn't work, then we go to Doximity. And then if that doesn't work, you can go to the telephone call, which isn't as good, but it's an option.
And then do you think, and I'll put this out to all the panelists, but it is a telemedicine question. I mean, is it telemedicine and the patient's preferences? Is that something that you think we think should become part of the intake when our patients are registering and either entering the hospital or entering the practice? Should we ask them if they have a preference for telemedicine?
I think that's a great idea. Both asking them if telemedicine is preferred, and then also asking them if there's any potential barriers to doing telemedicine visits. I think both would be beneficial.
I think it really depends on what kind of visit you're doing. I think, as Dr. Dorsey was explaining, I think for a post-op visit, when someone's doing well, that's very easy. You can look at an incision, not a problem. For some of our patients, you can't really do a complete physical exam, obviously. You can't feel for an aneurysm, you can't hear for bruits. So there are a lot of things that we can't do. It depends on, are you doing your study for the vascular lab the same day you see the patient is in the same location, in which case, if they're already going there, it's not an extra visit for them. Or are they going somewhere else and coming for a second visit? So I think you have to look at a lot of different features. The other problem is vein patients are much easier because on the whole, they're younger. But when you start looking at some of our population, I've tried to do televisits with some of them, and the technology, again, it's an issue of their understanding. The secretaries try to get them set up and they can't figure out which way to go on the phone, and it doesn't work as well for all of them. So I think that's a concern in our population as well. But I think we should continue to pushing forward with it. There's a role.
Yeah, and it was mentioned that you couldn't do telemedicine with the trainees because of, time restrictions, et cetera. But are we missing out? Should we be incorporating telemedicine into the trainees' education, and should that be, part of the curriculum actually going forward?
I think going forward, we're going to need to. When it first came out, we didn't know what we were doing. I mean, as we've all said, we were learning telemedicine ourselves, and we didn't know if it was going to be covered for them. You can actually supervise a trainee with remote. Family medicine's been doing a lot more than we have, because obviously that's what they do all day in and out, is the remote or the evaluations on exams. We're doing a lot of other procedures as well. So I don't know how many people in practice here have started incorporating their trainees into their telehealth visits. We haven't done that yet. They're back in the clinics, but they're not necessarily doing the telehealth. Are they doing them with you, Dr. Dorsey?
They aren't in our clinic, and that's mostly because we have brought them back in a kind of, in small portions. So we started with the second year medical students who they're the ones who couldn't shadow initially when the pandemic hit. And then we've slowly been integrating the first year students. But I know some other specialties who have started to integrate them into the telemedicine visits.
Yep. But I think going forward, at that. Sorry.
We're just about out of time. Perhaps we have time for one last question here. This is from Anil Hingarami. He's asking about the impact of the virtual resident applicant interviews, and wants to know if there were more programs interviewing more residents interviewing more programs, and how did all that play out, or how will that all play out in the match?
Yes and yes.
A good Linda question here.
There were more residents applying to more programs because they didn't have the financial limitations. So in the past, I mean, there's a charge for how many programs you apply to, but the bigger cost is getting there and paying for the hotel and travel. So people were definitely looking at more programs. I think the bigger question is going to be, did any of those applicants rank programs highly that they would not have looked at normally? Because a lot of programs did look at more applicants because they had more people applying and they didn't know who was serious and who was not. So for programs, I don't think we saved any time. I think for applicants, they were able to see a larger area. We know the match went well for us. Everyone matched across the country. We don't know whether or not everyone's going to be happy with who they matched. That's going to be really the question. And so is it a good match or not? Don't know. Next year, we'll find out at this time.
All right, thank you very much. Well, let me just share my screen here. And I would like to thank an excellent panel for their contributions to our town hall today on COVID 2.0, a pathway forward. And once again, remind the audience about the next town hall in a little over 2 weeks on May 17th. This will be an exciting one led by our SVS president, Dr. Ron Dahlman, on an evening with the appointments and nominating committees. And we'll see our new candidates for vice president, and voting will open. So with that, I'd like to thank my co-moderator, Dr. William Schutz, and all of our panelists, and bid you all a good evening. Thank you all.
Each year, millions of adults in the U.S. are diagnosed with vascular disease. And it's no wonder. With over 60,000 miles of intricate arteries and veins throughout the human body, there are bound to be complications due to blockages, weakening of the blood vessel wall, and other issues impacting the circulatory system. With an aging population and the growing incidence of risk factors such as diabetes, high blood pressure, obesity, smoking, and the disproportionate incidence of vascular disease in our minority populations, the management of vascular health is becoming a key focus among today's healthcare leaders and providers. As with any medical disease or condition, it takes an entire team of dedicated professionals to find new ways to efficiently diagnose and treat patients, as well as to improve their long-term care. In vascular health, The leader of the team is today's vascular surgeon. Only vascular surgeons dedicate their entire training and practice to address the full spectrum of vascular health, as well as provide comprehensive care that includes preventive, medical, surgical, and minimally invasive solutions. Through ongoing education and research, as well as pioneering new techniques, vascular surgeons are on the leading edge of clinical breakthroughs that are transforming vascular health. As part of their comprehensive approach, vascular surgeons partner with other healthcare professionals to provide quality care tailored to each patient. This patient-centered model is vital to help all physicians manage vascular health in at-risk populations and promote healthier lifestyles in the future. Vascular surgeons are involved in every part of the disease process, from making the diagnosis to the management of disease. Vascular surgeons are comprehensive leaders in vascular health. Today's vascular surgeons are creating a new chapter in the vascular health story with improved patient care, better outcomes, collaboration, and leadership. Surgery is only part of our story.